So today we're talking with Dr. Giovannini about anterior cervical discectomy and fusion surgery. So anterior means you go in through the front, right?
Right.
Cervical means it's in the neck part of the spine, what we
Right.
normally think of neck, right? Discectomy means?
Basically, we remove all the disc material from the affected part of the neck that's causing the problem, and we remove bone spurs, disc material, and then the fusion part of that is where we put a little piece of bone or a plastic spacer and then put a little metal plate on there, and that's called the fusion part of the procedure.
Okay, great. So if people say, I'm having disc surgery in my neck, they're probably talking about this procedure, is that right?
Well, there's actually two procedures. The most common is the anterior cervical discectomy and fusion going through the front of the neck. Now, for some people, we can go through the back of the neck, minimally invasive, and do a micro decompression procedure, but the majority of the cases are done from the front because it's really a very fast recovery, because we do not have to cut any muscles or anything like that, and it truly is minimally invasive to do it that way rather than go from the back.
Okay, so the first thing that I want to understand is, what are people feeling when they come to you? What kind of pain are they having, and where is it?
There's two types of problems. One, they can have a herniated disc where the disc material itself pushes out acutely. And then there's the arthritic condition called cervical spondylosis, and that's basically just a bone spur that's pushing on a nerve. Those two people will present differently. However, the symptoms usually end up the same. However, with both of them, they can present with a nagging neck pain, and then it'll start working its way into one of the arms as either pain or a paresthesia, where it's a tingling sensation that goes down the arm.
Is it like a numbness?
Yes.
Some people describe it as numbness?
Or it's an electrical feeling. That's why they call it a paresthesia. But it goes down into the arm, and usually people say, I move my neck to the side. Like if it's in this arm, they'll move it to this way, and they'll feel this jolt of lightning or a tingling going, or an electrical feeling going down their arm. And then if they let it go too long, it can be constant pain, constant numbness, and then they'll start developing weakness of the arm.
Oh wow, so it could actually affect their ability to grip things or their strength in the arm?
Absolutely.
Oh wow. Okay, so this is something that really will impact your daily life.
Absolutely.
At some point.
Yeah, if you develop paralysis, or which is a weakness, is a paralysis, or if you have a fixed, if you just have, most people just have severe pain. But trust me, these people, they'll come into my office and they'll say, can you cut my arm off? It's that bad.
Oh no.
I'm serious.
Severe pain.
It's that bad.
And so is there always neck pain, or sometimes it's only in the arm?
It can be either or, but in general, it starts with the neck, because that's where the process starts, with an aching in the neck. And then it'll start working its way onto the nerve, and then it starts going down the arm.
Now, is this something that the pain could start in the neck and move down the arm? Does it take years, or could it happen quickly?
Well, that's where the two processes that I talked about first come in. If it's an acute disc herniation, meaning the disc material itself comes out, then it's acute onset, meaning it occurs right away.
Fast. It's fast.
And it's days, or it could be right there.
Really?
You could wake up and you have this horrific pain, or you could be playing football or in a car accident. It really can occur anytime. However, with cervical spondylosis or bone spurs, that could be a gradual thing, and it can occur over years, and it can be intermittent. You could have 2 weeks of pain, and then it just kind of goes away.
Really? Why is that?
It's just the nerve accommodating to the situation.
Oh, so like the nerve, it might be irritated, but then it might get used to it?
Yes.
So then it's not, interesting. Okay. So can I ask you about this disc? Because I actually heard someone describe a disc as being kind of like a jelly donut.
Yeah, jelly donut that's encapsulated with, or it has a covering over it. And so when the covering wears out, you can blow a hole in it just like you blow a hole in a tire. And
the jelly
material
comes
comes
that's
out
the disc
and
material?
pushes on the nerve. Or the spinal cord, which is a worse situation.
Oh, so in the neck, is it the spinal? Could it be pushing on the spinal cord?
Absolutely. And in that situation, you could develop not only one arm, but both arms, or it can even affect your legs and your walking ability, and it could affect your bowel and bladder control if it comes out centrally against the spinal cord.
Wow, wow. And so is it possible, because you're feeling numbness, so the nerve is being affected, is it possible that that's permanent, or is that it's going to go away with surgery?
Well, I mean, it can go away with time on its own if the disc dissolves, or if the nerve was just bothered because of some activity that you did. And it can go away with physical therapy or with chiropractic manipulation or just taking anti-inflammatories. But if it gets worse and worse, more constant, you start developing a weakness, that's a sign that something probably is more progressive, meaning it's going to get worse, and you probably should have something done. If you let it go too long and you don't take care of the problem, then it can be permanent, yes.
Oh, wow. Okay, so it's important if you really need the surgery to have the surgery, because one of the risks is permanent nerve damage, is that right?
Yes.
When someone is having this pain, this neck pain and the arm pain, what kind of diagnostic tools do you use to really get clear on exactly what the problem is?
If it's just mild neck pain, then go to physical therapy or chiropractic manipulation. If it's intractable pain where they can't get out of bed, we need to get an MRI scan of their neck to see, because it's usually something bad. So depending on what that shows, we'd proceed with some sort of conservative option. And what I would do there is probably refer them to a good physical therapist within our network, and we have them all over the United States. And the best modality that I found in physical therapy or chiropractic manipulation is cervical traction. And basically that's where they have a device that can be computer assisted to a device that you hang over the door that you can do at home. But basically it lifts up on the head and basically decompresses or pulls the spine apart a little bit to relieve pressure off the nerve.
Oh, okay.
And hopefully get rid of some of that arm pain and get rid of some of the swelling around the nerve.
It reminds me of those old horror movies where they would pull people apart.
Right.
Okay, and so that's the primary pain management?
That would be the primary pain management would be anti-inflammatories, which we can prescribe, such as Motrin or Advil or something like that. We really don't like to do narcotics such as Lortab, Percocet, that kind of thing, because that leads to other problems.
Sure.
And usually in the end it doesn't work long term anyway.
Right. Okay.
So then the second step could be, if they just had cervical spondylosis, they don't want surgery, then we can send them to an interventional pain management specialist, which we have some of the best around here. But basically what they can do there are do some blocks in their neck with cortisone or methylprednisolone, and they can either do facet blocks, which are the joints in the back of the neck, or they can do epidurals where they put cortisone around the nerves, and that would be another step to avoid surgery.
And how long do those last, those blocks?
They can last a long period of time, or just a short period of time, or not work at all. But the bottom line, the risks are very low, and there's no real downside to it. If they don't work, fine.
Great. I know people who've had those blocks done. I know somebody who had one done because they wanted to go on vacation before they had their surgery. And so it was like they had that vacation booked and paid for, and they were going to lose all their money. So they did that, and it worked really well.
The problem is if the pain comes back while they're on vacation, that's a problem.
Yeah, that'd be bad.
Especially on a cruise ship or something.
Yeah.
Or in Bali or something.
Yeah. So, Dr. Gio, let's say someone comes to you and they're having the neurological symptoms. So they're having the tingling in the arm and some pain, and you order an MRI, and it comes back. What about the MRI is going to tell you, yes, they need surgery, or no, they don't?
Well, it's really not the MRI finding, surprisingly. Everyone thinks it's the MRI finding, and it's really not. What tells me someone needs surgery is number one, is the pain intractable? Will their pain, does it ever go away? Can they live with that amount of pain? Because I'll do surgery just for pain. And trust me, if someone wants their arm cut off because the pain's that bad, someone's going to want to have surgery. So that's the factor of the pain that I look at. Number two, do they have neurologic findings? If they have a paralyzed tricep or bicep muscle and they can't use their arm, or their hand doesn't work properly, that's another indication that would tell me this person should probably have surgery. And really, the number three, are the symptoms progressive? And what that means is, are they getting worse? They're not intermittent. They just keep getting worse and worse and worse. And oftentimes people escalate on pain medications. Nothing will help. None of the conservative modalities will help, such as the physical therapy, traction, or even pain management. To go along with that, if they have a MRI finding, such as a large herniated disc in the neck or a big bone spur that's pushing on the nerve that corresponds or explains their arm symptom, or explains the motor or sensory loss, or the weakness or numbness that they have in their arm, that all those go together, and if they all add up, I would recommend surgery for that patient.
So the MRI is just sort of one piece of the puzzle.
Absolutely.
There's several pieces. You know, as patients, you may have never heard this because we say this behind surgeons' backs. We don't actually say it to their face. But as patients, we say to each other, well, you know, if you go to a surgeon, they're going to recommend surgery because that's what they do. That's their tool. That's the one fix they have. And so as patients, when we come in and speak with a surgeon, and the surgeon tells us, well, you need surgery, then we feel like we have a decision to make, because just because a surgeon tells us we need surgery doesn't mean we're automatically going to say yes. We want to make the decision that's best for us. And so I'm just curious, from your perspective, as a patient who's going to decide, yes, I'm going to have this surgery you're recommending, or no, I'm not going to have this surgery, what criteria should I use in making the decision to either move forward with surgery or delay it?
Well, the three criteria I just gave, basically, is it progressive? Is it intractable? Is it really killing your lifestyle? Is it totally taking away your life?
So is the pain getting worse?
Right.
Is the pain making it so that I can't do the things that I want to in my life?
And do you have a deficit or a weakness or a numbness that's getting worse to where your arm's becoming dysfunctional, or both arms? But the way I'm going to clarify, the way I help guide you in that decision is this. And I turn away 90% of the people for surgery anyway. So
really,
basically, the way I guide that discussion is this. If I feel that I'm going to change your life, get you back to everything that you want to get back to, and I feel that you're putting yourself at risk for permanent neurologic damage, I'm going to strongly recommend surgery, and I'll actually insist that you have surgery. Not that you have to go with what I say, but I'll say it in that manner.
Yeah.
Now, oftentimes I'll ask some patients that I've done in the past, with their permission, to talk to somebody to give their story of what they went through, so the patients feel safe. I mean, that they feel that it's not some sort of it's a safe procedure. So but on the other hand, if the patient just has mild pain and they have a moderate problem on their MRI, then I'll suggest basically that surgery is an option, but if you're hesitant about it, maybe try these other modalities. And So I basically curb my discussion on basically for safety for you. And are you going to ruin your life by not having the surgery? I'm going to be stronger, in my opinion, to you. And so that will help you make the best decision you can for yourself.
Sure.
You can lead a horse to water, kind of thing.
Yeah. Yeah. Surgery is really scary, and back surgery in particular is really scary. So we're talking about this anterior cervical discectomy and fusion now. So in terms of having this surgery, what do you think is the biggest fear? Like, what's the biggest fear that you hear from your patients about having this surgery done?
The biggest fear is fusion.
Fusion.
The word fusion. And it takes, when people hear the word fusion, they think disability. They think they're going to be immobile the rest of their life. They're going to limit their range of motion. It's going to change. It's going to make them worse, not better. And then down the line, they worry about the other disc. Is it going to cause problem with the other disc? That can be true. However, neck fusion surgery does not inhibit your lifestyle. Now, if you're going to have every disc in your neck fused and then you're going to do it have a posterior procedure in the back of the neck too, yes, but usually we only do those for people that have severe problems, that have problems with, they're going weak in all four extremities. They can't walk. They're in a wheelchair, that kind of thing.
So they're happy to just be upright.
For the general population, fusion surgery will improve your lifestyle. There's a famous person, I did not operate on this person, but Peyton Manning, who's a quarterback, had a fusion surgery, and he's playing in the NFL.
Yeah.
And that's well known. It's on the internet. You can look it up and look at his story and all that kind of thing. So, and athletes can get back to doing athletic competitions after this type of surgery. But that's the hardest hurdle I have with patients. They're afraid of the word fusion.
Wow. And so even with a fusion, you can play professional football.
Correct.
That's crazy. That's crazy. Yeah, because I think we do have this misconception that fusion means you'll never be able to turn your neck. Where it's cervical.
And that's absolutely not true.
Wow.
I mean, basically, fusion surgery to the lower segments in the spine does not inhibit rotation or turning your neck at all. You may have a slight decrease in flexion, extension, this motion, but it really doesn't affect the range of motion to that degree.
Well, now, go ahead.
Well, the other thing is we live in the Panhandle here, so we see a lot of pilots that are in the Air Force or in the Navy.
Yeah.
And we do this surgery all the time because they have a lot of, with the ejection seat and the G-forces and all that kind of thing that they experience, there's a high incidence of neck problems with these pilots.
Yeah.
And we can do the surgery and they can go back to flying these high-end jets.
Oh, awesome. So it doesn't affect their medical ability to fly jets even?
No.
Wow. Describe to me the procedure, like what a patient can expect and then what you do during surgery for an anterior cervical discectomy and fusion.
Yeah. Basically, in a nutshell, this is done as usually an outpatient procedure.
Wow, outpatient.
Yeah, and
so you go home the same day.
Yeah.
Wow.
Some people will have to spend the night for 12 hours, but it just depends on how things go. But 90% of the time, they can go home 4 hours after surgery.
Wow.
But basically, they come in, and this is done under general anesthesia. It has to be. And it's for the patient's safety, and there's really no way to do it under local. But it depends on how many levels are being done. But in general, a one-level surgery takes about 45 minutes of general anesthesia.
Wow.
That's it. And basically, after everything's ready, we take the patient to the operating room. we approach it from the front of the neck. So we use a nice little skin crease. That skin crease, we'll do a small horizontal incision that's in the skin crease itself. So when it heals over 6 months' time, you probably won't see it.
Yeah, I talked with some of your patients at your holiday party, because you have a Christmas party every year, and you had a lot of patients there at your party, and they would say, "Oh, look, he did it," and it was like I'd have to squint to see their small little scar.
Right.
You couldn't see it.
Well, it's not really how big it is. It's that you got to use the skin crease. So when I'm actually in the surgery, I actually take the skin and I actually go like that and find that skin crease, and then I'll draw a little marker.
Yeah.
Because obviously you want to do it in a plastic surgeon type manner.
Yeah.
To where it looks natural on the neck. And
well, I have to say you do it, because they were invisible, the ones that I saw.
So anyhow, then we never cut any muscle. Everything's done through natural tissue planes.
That's huge. Never cut any muscle, because not every surgeon does it that way, right?
Well, for that procedure, it's pretty standard.
Is it? Okay.
In fact, people come to me and say they want minimally invasive anterior cervical. I said it is minimally invasive by the virtue of going through the front.
Oh, okay.
The misnomer is that minimally invasive surgery is a concept. It's not a well-dictated, it's basically low blood loss, minimal scarring, and less tissue damage. So however you accomplish that, it just so happens that this surgery itself is minimally invasive.
Just the design of the surgery.
Right.
And when you say tissue damage, you mean muscle.
Or any structure.
Okay.
But
okay.
mostly muscle tissue,
Okay.
yes. So in any event, everything's pushed to the side. When you go down, you go down to the front of the neck or the anterior part of the neck. And then basically once we get to the front of the neck, we basically drill out the entire disc or take out the entire disc. And then if there's bone spurs there, we drill those off with a high-speed drill. We use a high-powered microscope for better visualization, and we can zoom in and look at what's going on in more detail, and it's safer and more precise that way. So once we get all the disc material out, we drill off the bone spur. Then we have to fill that space.
How do you get the disc material out?
I use a drill to get all the disc material out, and then we have some micro instruments to kind of tease everything out.
So like suction, you use suction and that kind of thing?
Yeah.
Okay.
And so once all that's out and the bone spurs removed and the nerves are, there's no pressure on the nerves or the spinal cord, then we have to fill that space, because if you don't fill the space, in the old days they used to do this without doing that, and the disc would collapse. And then you would have problems, because where the nerves come out, where the foramen are, where the nerves come out, they would be recompressed because of the disc collapsing. So we put either a donor bone in to fill the space and keep the space open, or we some people can put a plastic cage in there, or whatever they want to use I use a donor bone in 99% of the cases. And then we put in a small titanium plate that's MRI compatible, so you can have a subsequent MRI without the artifact of steel. And once that's done, we basically, everything kind of falls back together. We close it up, put some glue on there so that you can shower the next day, and then you basically go to the recovery room, you wake up, and hopefully all that terrible arm pain, all the tingling, and most of the strength is recovered. And then about 4 hours later, if everything's fine and there's no problem, you can go home.
That's crazy. That's crazy to me. That's incredible. That's incredible.
Right.
I mean, you have major neck surgery. I mean, to me, it's like that's a big deal, what you just described, and you go home 4 hours later. That's awesome. That's awesome. So when a patient has had the anterior cervical discectomy and fusion, and then they've been through this surgery, and they wake up in the recovery room, what can they expect?
In general, 95% of the patients that were having extreme arm pain will wake up with no pain. Most of or all of their pain should be gone. Now, some people do have some delayed swelling and some delayed pain that may come back 3 days later, but it usually goes away. But in general, it all goes away.
Wow. I mean, immediately.
Right.
Wow.
Now, the
Wow.
strength isn't going to come back immediately, but it can take days. But usually, in the rule of thumb is if it took 6 months to get weak, it may take that long to get better. But most of the people, it goes away right away.
Wow.
And the numbness and the tingling, all that gradually goes away as well.
So is there any pain anywhere then?
They have a little bit of throat pain, a little raspiness in their voice maybe, a little trouble with swallowing for a few days from us pushing the esophagus over.
I see.
And really that's it.
Wow. And you know, to me, going through anesthesia can be difficult on my body. I always feel like it takes my body a little bit of time to sort of get started again somehow. So what I love about this surgery is that it's the time that you have to be under isn't that long, but you still are under general anesthesia. Are there any after effects from that you see?
In young people, usually there's no effects. As you get older, the anesthesia affects you a little bit differently. If it's done as an outpatient, it forces the anesthesiologist to treat it like an outpatient. So then they use lighter techniques, and that's what we do because most of these people are outpatient or ambulatory, meaning they go home that day. So they have to give a technique that they're ready to go home.
Yeah.
And so that makes it easy to recover from. So I really don't see many problems with this surgery for post-op delirium or anything like that. Or a lot of people, when they have general anesthesia and get a lot of fluids pumped into them because people lose some blood or something like that, they'll have post-op ileuses, which is where your bowels stop. We never see that with this procedure.
You never see? Okay. It sounds like incredibly transformative right after the surgery. I mean, you're going to get back to doing what you want to do. So I've made it through the surgery. I've gone through the recovery. I've gone home. What do I need to be thinking about once I get home?
Well, when you get home, you're going to feel great. And a lot of people, I tell them one thing, they do another. I mean, if you watch some patient testimonial videos, you'll see he told me to stay off work 2 weeks or something like that, but they went back the next day. That's how good most people feel from this procedure. But if you have bad bone, meaning it's soft bone or osteoporotic bone, I'll make you wear a collar for 4 to 6 weeks or something like that, depending on how many levels. If it's just one level, I never usually use a collar, even with osteoporosis. Multiple levels, I'll make them wear a collar. And
for how long?
4 to 6 weeks. If they have real soft bone. And I can tell that when they're in there. We can get DEXA scans and all that kind of thing, but really what tells me is how the screws go in, how the bone feels when I drill it out. That's really the tells me whether they need a collar or not.
I see.
So if you're not wearing a collar or anything like that, you're able to turn your head as much as you want. We want you to limit the flexion extension,
That's the up and
down, just a little bit to let the bone graft seat in there.
More no's than yeses.
Right. And then basically you're up walking, doing the normal things. People ask me, do I need help at home? Really, no. I mean, you can really
shoot.
Yeah. Well,
I always like help at home.
Well, I always get the women want me to get the husband to or sign a prescription, no housework.
That'd be great. I like that.
the running theme, I think. But in any event, really, it's a very easy recovery, and then it's 4 to 6 weeks. You're really able to do whatever you want to do.
That is incredible. That is incredible. And when I think about how much people really agonize over this like, oh, I don't want to have surgery, I don't want to do it, and to think that it's a 45-minute surgery and they wake up 4 hours later with no pain and they can go home most of the time, I mean, that's just incredible. Just incredible. So Dr. Dio, I've heard of these disc replacements. So how do I know whether the anterior cervical discectomy infusion is best for me, or if I should be considering, or if you would consider, a disc replacement?
That's a good question. We do disc replacements. and the way we choose one over the other is the true indication for disc replacement is younger people that have a soft disc herniation with mobility of the cervical spine. So what that means is someone with a herniated disc, not in general cervical spondylosis, but some can be done, and they show on x-rays or that their spine moves. And so if all those are in play and it's now there's a 2-level disc replacement that's FDA approved, we can perform a disc replacement.
And is it preferred or non-preferred? How do you decide?
I usually choose people that are younger, that have a soft disc herniation, and basically it's 1 or 2 levels. And the results show that that it's equivocal results, meaning that an anterior cervical discectomy infusion does just as good as a disc replacement.
Oh.
However, the caveat is this. The problem with anterior cervical discectomy infusion that one may ask is it can cause accelerated deterioration of the discs above and below the fusion. So down the road, that may mean that your other discs are going to wear out. And a fusion can accelerate that. That's well known, it's documented, it is a fact. Mm-hmm. So the answer to that is disc replacement, because it allows some motion. Theoretically, it should reduce the wear and tear on the next levels.
And is there any information that actually proves that that's true? Has it been around long enough to even have studies?
In Europe, there's been tons of disc replacement in the cervical or in the neck and the back. Uh-huh. And there's studies that basically show that there is reduced deterioration of the adjacent disc in the neck.
All right, so if you meet those 3 criteria, then it's something to consider.
Yes, and we can do those. We do those all the time.
Okay, great. So, Dr. Gio, I've read on the internet, your favorite thing, right?
Yeah.
I read on the internet that one of the downsides and one of the concerns about having fusion surgery is that it puts stress on the discs above and below where it was fused. Is that true?
Absolutely. And that is one of the downsides to fusing the neck. So if you're not a candidate for disc replacement, which is a way to kind of counteract that problem, fusing a segment in the neck will cause stress on the adjacent segments in the cervical or neck and cause wear and tear on those discs. And there's certain percentage of patients will come back having to have further surgery on the other disc because of that, what we call adjacent level deterioration.
And so does it happen with everybody? You just have to expect it, or does it seem more likely for some people?
Radiographically, it happens with everybody.
Okay.
Symptomatically, it's probably around 20%.
Oh, okay.
And then requiring surgery even less than that. But we do it quite frequently. People come back 2 years, 5 years down the road and say, I'm having that same problem again, but it's in a different distribution. It's a little bit different this time, and we'll get an MRI and it will show wearing of the next disc.
And then what do you have to do then?
Basically the same procedure.
Okay. All right. So now you said you were putting in the neck where you fuse it some titanium plates and screws. Have you ever had any problems with those failing?
This technology has been around a long time, so all the problems we saw 10 years ago, or actually when I started this, I think I've been doing this 20 years now, we used to see a lot of screws back out, broken screws, plates failing, this kind of thing.
Yeah.
But today, these days, I rarely see that. Now, you can have a non-union, and what that is failure to fusion. Some people may not fuse, and when that happens, the plate can loosen, and sometimes it can back out. But I rarely see that. In fact, I hardly ever see that in a one-level case, hardly ever see it in a two-level case. In a multi-level case, you can kind of see those things go on, but we monitor that. We actually see it back 6 months, and I even see people as far as a year to monitor their fusion.
And what causes that when it doesn't?
It's just, if it doesn't fuse, it means the bone graft didn't take.
Ah, okay.
Rarely do we have to reoperate unless there's really a bad screw back out or something like that. But with the titanium plates that are made today with the anti-back out mechanisms, I rarely see any problems with that.
Now, I know this probably seems like a silly question, but I have to ask. So if you have these titanium plates, like, are you going to set off alarms and things?
No, it's titanium, so it really doesn't cause any problems.
So I have the surgery, I come out, I'm doing well. 2 weeks I'm sort of taking care, not doing this up and down motion a lot. I come back in, and do I see you 2 weeks after? Like, when do I see you again?
We don't have to take staples out or anything like that. We use glue. So we're going to see you back in 1 month. I get an x-ray just to make sure everything looks good. And then after that, I'll see you 6 months and a year down the road.
6 months a year, okay. And so after the 1 month, do I have any physical limitations, anything?
In general, no.
Okay, great.
Now, the fusion does take up to a year for things to become stable in there where you can really do most activities within reason. It's about 4 to 6 weeks.
Wow, that fast.
Yeah, the fusion doesn't take that fast,
Yeah.
but the ability where things are stable and nothing's going to happen to the hardware or anything like that.
That's great. So 4 to 6 weeks till it's stable, and then about a year for the fusion to really be fully completed.
Correct.
Okay,
Some
great.
people faster than others, and really most young people I'll see x-rays in 6 months and they'll be completely fused.
Great, all right.
Then remember that the plate is not the fusion device. The fusion is the bone graft that's in there that causes your own bone to fuse. The
Tell me about that. What's the bone graft?
The bone graft is just a piece of donor bone or from a cadaver that's put together. It's all tested. It's all these things. There was a period where there were some problems with the testing and all that. Now it's highly tested. It's documented. They can track where the material came from, and really it's a machine bone graft that I use, and it's very safe. But the plate is just an internal collar, basically. It allows no motion to occur so that bone, everything is stable and nothing can happen. The bone graft can't back out, and it allows things to fuse. Over 6 months, really, you don't need the plate anymore. We don't go back in and get it out, but it's just a temporary bracing
For the
internally.
bone graft. For the bone graft.
Yeah.
Interesting.
So think of it like a collar
Yeah.
inside.
Yeah, interesting.